Artificial Intelligence Doctor. User question. Can you give me your opinion about this electrocardiogram showed in the two attachments? GPT 4.0 answer. Thank you for sharing the ECG strips. Based on the 6-limb lead shown in the two images, here's a structured interpretation and clinical opinion. ECG overview. Heart rate and rhythm. Regular rhythm with consistent RR intervals. Heart rate approximately 50 BPM, bradycardic range. Likely sinus origin. There are visible, upright P waves in lead 2 before each QRS complex with a consistent PR interval. This suggests sinus bradycardia. P waves and PR interval. P waves are best seen in leads 2 and AVF, preceding each QRS. PR interval appears consistent across beats and within normal limits, 120-200 ms. Suggests normal AV conduction. QRS complex. Narrow QRS complexes, less than 120 milliseconds, throughout, suggesting supraventricular origin. Axis appears to be normal to slightly leftward with positive QRS in leads I and AVL, negative QRS in AVR. ISO, to slightly positive in 2, variable in 3, could suggest borderline left axis. ST segment and T wave. ST segments are isoelectric or slightly upsloping in some leads, 1, 2. No signs of ST elevation or depression. T waves upright in 1, 2, AVL, AVF, inverted in AVR, which is normal. Interpretation summary. Parameter finding. Rate, 50 BPM. Rhythm sinus bradycardia. P waves present, upright in 2/AVF. PR interval normal and fixed. QRS duration narrow. QRS axis normal to borderline left axis. ST/T no acute changes. Clinical impression. This is a sinus bradycardia with normal AV conduction and no acute ischemic changes. It may be physiological, e.g., in athletes or during sleep, or pathological, e.g., vagal tone excess, hypothyroidism, medication effects, sinus node dysfunction. In the context of your prior conversations regarding leadless pacemaker, if this was recorded during an episode of intermittent capture or loss of capture, then it's critical to correlate with pacing artifact and capture analysis in the corresponding device interrogation. Recommendations. Clinical correlation is essential. Symptoms, e.g., dizziness, syncope. If under a leadless pacemaker, check pacing mode, thresholds, and whether the pacemaker was intended to pace at 50 BPM, i.e., this could be native sinus. Consider longer-term monitoring, e.g., Holter or remote telemetry, to detect nighttime pauses or capture failure if relevant. If asymptomatic and known baseline bradycardia, this may be benign. Would you like this put into a short educational video script as well?